going to go ahead and get started. My name is Erin Braun. I'm a program coordinator with Western New York Rural Area Health Education Center. We are a nonprofit in Worcester, New York, and our goal is to provide health education for our rural communities. Thank you for joining in with me today for our final week of our Choosing Hope webinar series. So the goal of our webinar series has been to bring awareness and education in the realm of substance use and opioid use disorder, the stigma that comes with it, as well as recovery and treatment methods. Today we have Dr. Davina Moss, who will be speaking with us regarding substance use and women in pregnancy, along with implicit bias. Today's event does count for 1 hour of New York State OASIS CEU credits. So Dr. Davina Moss is the founder and president of Positive Directions and Associates, a consulting company that provides educational seminars for medical professionals in the community and navigates pregnant women prescribed medicated assisted treatment through pregnancy, delivery, and postpartum. Dr. Moss is a trained perinatal mental health counselor, certified rehabilitation counselor, a national certified counselor, and has been a credentialed alcohol and substance abuse counselor for 28 years. Dr. Moss is an adjunct professor at Canisius College's Counselor Education and Human Services Department in Buffalo, New York, and an adjunct professor at New York University's the Steinhardt School of Culture, Education, and Human Development Department of Applied Psychology, Master of Arts Program in Mental Health and Wellness. Dr. Moss is also an instructor for NET-CE for medical professionals, and she offers trainings approved by New York State Office of Addiction Services and Supports via her organization, Positive Directions and Associates, and the Western New York area for medical professionals, as well as substance use disorder counselors and behavioral health specialists. So let's please wait to leave questions until the end of our presentation, and you can use the chat or the Q&A in your toolbar. So I'm going to pass it over to Davina.
Good afternoon, everyone. Thank you so much for having me today. I will have subtitles during the time of my presentation, and our interpreter, Jesse, will also be interpreting the information that I will be giving to you all this afternoon. If ever there is a time that I'm moving too quickly or I'm speaking too quickly, please do not be ashamed or shy to basically state, could you please repeat that? Or can you please slow down? I have no problem with that. I want to make sure that we get all the information that is important for what we practice as counselors, medical professionals, as well as what we do within our community. So with that said, I will begin and share my screen. Jesse, is it okay that I turned my video off?
Yep, that's fine.
Awesome. Thank you so much. Before beginning, I wanted to definitely say thank you to the sponsors of having me come to speak with you all today. RC Corp, R-AHEC, Spectrum Health and Human Services, and New York State Office of Addiction Services and Supports for the 1 hour continuing education credit that will be given to you in the event of a CASAC renewal. We have 3 learning objectives for our training today. The first is all of our participants will begin to understand some of the negative effects of implicit bias on our pregnant patients as well as our clients that we serve. Second, participants will learn and understand how stigmas such as mental health and substance use disorders impact the provider, impact the patient, as well as the client-patient relationship. Third, our participants will learn some techniques for motivational interviewing, which most of us are familiar with, as well as cognitive behavioral techniques to improve our collaborations, conversations, as well as recognizing implicit bias. The one sentence that I wanted to start with us for today is always see your patient's heart first. Seeing your patient's heart first means that you're looking beyond their social economic status. You're looking beyond what may be on the medical record or previous or past failures or previous and past inability to follow through with treatment as well as prevention. When you see your patient's heart first, you realize that there is a story behind what your patient is going through. And sometimes it helps us as clinicians and as providers to be patient. Maya Angelou is one of my very favorite poets. She has a wonderful way of discussing what I wanted to talk with everybody today is, and this is a sentence, two sentences that make a difference. There is no greater agony than bearing an untold story inside you. Prejudice is a burden that confuses the past, threatens the future, and renders the present inaccessible. As we're going through our presentation this afternoon, I want you to realize that every patient that we have has an untold story. Unless we are willing to look at our patient through their heart and understand their worldview and their lens, we're unable to assist them properly, and it will threaten the future relationships that our patients will have to be successful in their treatment, recovery, as well as pregnancy. When we're looking at implicit bias, implicit means within. Majority of the time, everyone lives in an environment, and as children, we are sponges. And as sponges, we take in everything in our environment. You may hear some parents say, "My child never listens to me." You may hear clinicians state, "My patients never follow through with their treatment and never listen to me." However, what we have to always understand is there is a backstory. There are other situations that may actually be happening prior to your patient coming to you. Majority of this begins in our environment. And as we talk about being a sponge, the sponge is actually our brain. So what you see in this picture is a brain. And there are all of these small clouds and things around the brain, which basically shows you what your patient may have within their mindset or their worldview. Let's start with culture. Culture is something that your patient may learn from childhood, carries on with them going through adulthood. With that culture also comes into a drug culture. So we'll need to understand what that means from our patient's point of view. What does family mean to your patient? What does their marital status mean? What is sexual orientation for them? Are they accepted within their circle, within their environment? Are we as clinicians and medical professionals accepting of our patient's sexual orientation? Ethnicity and appearance and race, gender and age. And lastly, income. Socioeconomic status is something that is embedded in our society as well as in our community. And sometimes what we have within our minds of economics comes forth in our speech in the way that we may possibly treat our patients. When you're looking at this picture, you have different types of individuals, and you have on the right side of your screen, you also have two different brains. So what these two individuals are doing is identifying and looking at the pictures on the left, and sometimes these words may come into their thought process in their mind, such as be careful, or there's a strong girl, or there's fear. I'm not tolerant of this particular individual. All of these pieces come into our mind long before we are professionals and can carry out through our thoughts, words, and actions as we are working with our patients in our various different sites. When we're thinking about who we are working with, and notice my terminology, it's not who we're working for. Who are we working with? And what are our thoughts about our patients that we are collaborating with? The first is, and I want you to think about this, and you can actually write some items in the chat of how you are thinking about this particular patient. The first is a pregnant patient that admits to using marijuana on a daily basis to relieve anxiety. What are some of your thoughts that you can possibly put in the chat of what are your thoughts regarding this patient who may use marijuana on a daily basis to relieve anxiety? And I'll give you a couple of moments to write that in the chat. And then if you would like to read to me some of the thoughts that come into the chat, it would be greatly appreciated. If anything comes in, you can read them now, it'd be great.
Davina, are you talking to me to read the chat?
Yes, please.
Okay. So Jessica said, a question, is this a form of harm reduction?
Good thought, excellent. Thank you so much.
And Samantha says, perhaps she would be open to considering a safe medication to help with anxiety instead of smoking.
Love it, love it.
Megan Boring says someone who may not know of any possible side effects on baby.
Mm-hmm. Excellent. The second, I'm sorry, were there any others in the chat? I didn't want to leave anyone out.
No further statements or questions as of now.
Awesome, thank you so much. Number 2, a patient that is pregnant admits that she is in recovery for alcohol. Any thoughts about this patient who is admitting to you during their time, whether it be at an OB appointment or at an outpatient recovery appointment, but this patient is admitting that she is in recovery of alcohol? What are some thoughts that may come to mind for you all?
Nothing so far. Oh, she is ready for help. She wants to be sure the baby is okay.
That is excellent. And that's looking through a lens of knowing that this woman is here for assistance. And right now is the prime time to help, to either have her go into treatment or to create a treatment plan that is conducive for she and the baby.
If they are in recovery, they may need access to a support group or other support mechanisms to keep the baby and patient safe.
Excellent, excellent. And I think that answer could also be applied to number 3 too, which states the pregnant patient admits she uses cocaine on occasion. And that treatment statement that was just mentioned, I think, is perfect.
And then we have, what coping mechanisms is she using or need help achieving?
Excellent, excellent. So when we're looking at coping, we're looking at treatment mechanisms. We're identifying, does the patient need to be in a patient setting, or are we able to actually handle this in an outpatient setting, but making sure that the patient is engaged at least once every other week, at least be involved with groups, and at the minimum be able to attend any type of self-help type of organizations that they're able to, working around their schedule of work, as well as if they have other children. The last scenario is a pregnant patient that admits she uses heroin daily and has had difficulty on medication-assisted treatment. What are some of our thoughts we may have from scenario 4, where the patient admits she's using heroin each day and has difficulty in the past with MAT? What are some of your thoughts?
For question 4, if medical assessment is not helping, perhaps a sponsor or a relationship-based support group would help the patient avoid the drug by having someone to talk to, excuse me.
Love that. Sometimes peer advocacy is the most strongest piece of treatment that we have. And I am a definite huge supporter for peers when it comes to recovery for our moms.
Support her through the process of finding a clinic or medication that works.
Yes, yes. And I like that you said find a clinic. And later on in the talk, we're going to talk about making sure that clinics, facilities is a good fit. Because sometimes it may not be the best fit for our patient. So I really like that you mentioned that. So hold on to that thought.
It seems like she's reaching out for other ways to help her.
Yes. So she's saying MAT didn't work for me in the past, so I'm not sure what else to do right now. And we'll be able to assist with that. Are there any other thoughts in the chat? I didn't want to miss anyone.
So far, no more.
Excellent. I'll move on to the next slide. Thank you all for participating and engaging into that section. When we're looking at addiction, we're understanding that there's a health to addiction, there's a biology to it, psychology to it, and a health and a social context. When we're looking at the biology, we really want to identify what are some of the stress reactivity that happens. So earlier I had asked about anxiety, and one of our participants put in the chat, we want to find out if a person is using a substance to help with anxiety, to help with calming themselves or handling stress. That is perfect. You're keeping in mind the biology. The next is the psychology of it. What are the emotions, the coping mechanisms? What are some past trauma that our patients may not have discussed in previous counseling sessions with others or with us, that now this past trauma is coming forth now that we have a patient who's pregnant. Pregnancy brings on various different hormones, and sometimes past trauma is the number one piece that comes to mind. With that, emotions are difficult to regulate and coping mechanisms may not be there. So it will be our responsibility to identify what is happening with our patient and what will the patient require some coping mechanisms. And that you really started looking at as you engaged in the previous slide when you're seeing the patient's worldview, which is you were looking at that patient's heart first in order to assess properly. The last is the health and the social context. This is really identifying the cultural traditions of your patient, identifying their social economic status. Social supports is very important, not just who is supporting them within their family, but who is also there to support them as far as peers, socially, what are they engaged to, and education. When you see education in this slide, I don't want you to think of K through 12 for education. I want you to think about how well does your patient understand their addiction? How well are they educated to understand the biology behind it, the chemistry behind it, and what actually can happen as the patient continues to use substances while pregnant? Education for your patients is definitely empowerment. So as we're continuing with our talk, I wanted you to keep in mind the biology, psychology, health, and social context. There are some quiet bias thoughts regarding substance use disorders that sometimes individuals may not discuss. Our colleagues may not say it outwardly, it may come out in different ways, but it's very important for everyone to do a self-awareness check to see if there are any quiet biases that will have a negative impact on your relationship with your patient. Some quiet bias thoughts are, as we see on the screen, the substance user does not have values or morals. The substance user's problem is their own and no one else's. There is problems within that family, and the substance user is the problem of the courts and the legal system. This last piece is important because some of the patients that we may work with and we're collaborating with may have court cases, may be mandated, but realize it is not a problem of the system. It is our entire responsibility that everyone has a role where our total bottom line is health, welfare, and safety of our patients. So really keep in mind what are some of the biases that we all may have quietly that we do not talk about amongst our colleagues, but we are aware of them. So throughout the presentation, really start to think about what is our own personal self-awareness. I will not ask you to share, but I am asking you to give it some thought. Some of the values that influence behavior. When we're looking at what we value most about ourselves and we value about what we do. Personally, we have a personal value of respect, love, and relationships. When we transition those personal values into professional values, our respect turns into integrity. Our love turns into the compassion that we have for our patients and the passion that we get up and we go to work every day, whether it's virtual or in person, we're giving our 110%. And majority of us always have the thought of being very compassionate with our patients, and which is a wonderful way that we're able to help our patients through their transition. We also have a personal relationship for relationships. That value turns into altruism. Altruism is why we're all here and why we all do this work. I often bring in to many talks that I give about the value system, what we value personally and what we prioritize as our own personal values actually become interpreted into our professional values, which helps us to move forward to help the patients that we work with each day. As we're working with our patients each day, as we have self-awareness every day, as we're following through with what our value system is and what we prioritize, it helps us to realize that our values also turn into our language. Language is the way that we interpret and the way that we may communicate with our patients. The language that we are to use is on the left side of your screen, and the language that we are working very hard in the field to avoid is on the right side of your screen. When we're identifying language to use, we try to make sure that the language that we are using is inclusive. Also, making sure that this language is positive for our patients, and understanding that the language that some of our patients have heard over years has been pretty much negative and making the patient not feel worthy and making the patient not feel valued. So keeping that in mind helps us to understand that as we're discussing, writing our notes, having conversations with family members, with our patients, and we are collaborating with our patients, we are going to work very hard on our language that we use. So the language that we definitely want to avoid, and the number one that I've had to work on for myself, actually is saying the word relapse. I had a patient who explained to me that when you use the word relapse, it makes me feel like I'm really not a good person. And I know I made a mistake. I know I screwed up, but I hate when you use that word. So I asked my patient what word would work better for you. And very simply, the patient said to me that I made an error. I used because. He said, I want to focus on why I used, not that I used. That made a lot of sense to me. So when he had the situation of using the drug of choice, my question was, what was the situation of the using? And the patient was able to express to me what that situation was. And we focused on the recovery and the treatment and the coping mechanisms related to that situation, which really helped. I find that this also helps a lot with our pregnant patients, mainly because our pregnant patients have many layers of concern. First layer is wanting to be in a position to give birth to their child in a healthy state of mind and physically healthy. That is one layer. The next layer that our patients have is trying to make sure that the focus is always there on the baby and not on possibly using any drug of choice that is going to cause harm, and educating. So what I have found through Positive Direction, my company, that we work very closely with pregnant moms, is to work on what situations do you need assistance with coping? What situations may cause you to begin to wander and to think in your mind that you want to manage your emotions by using your drug of choice. When we decide that it is a management issue, now we're able to get to the bottom of it and really work well during the pregnancy. Some words that we want to use that possibly may help is medication for opioid use disorder, or medication-assisted therapy. Many times we've gone through, I've been in the field for 31 years, and we've known it as methadone clinics and other types of agencies. But if we're able to definitely state that it's medication for opioid use disorder, that helps and follow through better. Also looking at heavy use or return to use, or focusing on this situation happened to me. As a result, I was not able to continue with my recovery and I returned to use. So assisting with this language helps, and it also becomes a microcosm because your patient begins to use that language themselves in speaking with you as well as other providers. There's some conflict that may happen while we are working very closely with our patients that I wanted to focus on a little bit. As a professional, we may become very frustrated in various different situations, mainly because we're looking at return to use for some of our patients. And if our patient is pregnant, we become very frustrated to try to understand how this happens and how we can actually assist and manage better. But looking on the other end of this, as we are frustrated and as we may show our frustration on our face, and as we may work with the stigma that we may have, our clients may also fear change. Sometimes we may have pregnant moms who do not know any other way to manage their emotions except by using their drug of choice. that is a way that they are fearing change, but in turn, as a professional, we become very frustrated. As a professional, we may feel very powerless over various different situations, not being able to have a provider available immediately to be able to start an initial piece for medication-assisted therapy. We may feel very powerless. As a result, our clients become very frustrated too. As a professional, as we're going through the stigma that we have, we may actually become angry at certain times. Anger is something that everyone experiences. I often state when I talk about self-care for providers, medical providers, and for clinicians, is anger is an emotion that is natural. We have to work through it and we have to discuss it in supervision. The anger that you may feel actually may come from the patient who's had past experiences that were not successful. So the patient may come in with a chip on their shoulder or may come in not being very forthcoming to you as a clinician, and that can cause some anger. Lastly, from the professional and the client is communication, keeping the lines of communication open, keeping them positive and encouraging, and always expressing how important it is to talk about ways that emotions are not being managed properly, especially for our patients who are pregnant. We have to try very hard to assist them with writing in a journal, identifying ways that they're able to talk outwardly about what's actually happening. This way, we are able as medical professionals and as clinicians to really get in on the heart of what's happening with the patient. So communication on both ends is important. As a clinician, you may notice something different about the patient. Bring that to the patient's attention. Because of that therapeutic relationship that you have developed and you've worked really hard on, it gives you that window of opening to be able to communicate ways that you notice that there could be some concerns later. And basically, you're doing a lot of prevention and intervention so that it's a healthy pregnancy for your moms that you're working with. There are some psychosocial concerns regarding opioid use disorder and other SUDs. The first is social supports. Through COVID-19, we've learned other ways to support virtually. We've learned how to have Zoom meetings, Google Meet, other ways to assist our patients. So identify what those social supports look like. There are some social factors that are definitely involved with our patients: status in society, integrating into the OBGYN office. Are they welcomed? Some patients who are pregnant will not go to an outpatient appointment or may not get prenatal care because of being ridiculed or looked at differently. So always making sure that there is a welcoming integration into your clinics, into your OBGYN offices. Looking very closely at socioeconomic as well as race factors. How are we definitely addressing race factors? How are we definitely including all patients into our offices and making sure that there is some mental wellness happening? Are there pictures on the wall that can talk to your patient about mental wellness? That mental wellness basically takes a look at how well your patient is treating themselves and doing self-care. That will turn into later how healthy the pregnancy will be. So what are also the thought process and behavior changes and responses, or CBT, cognitive behavioral responses that may happen? Giving education and empowering changes the thought process of your patient. When you're looking at the thought process, that also interprets into more positive behavior, different types of activities. What are those responses? You would like to take that situation into parenthood for your patient, because there is going to be a continuation of making sure that we work on these cognitive behavioral responses as mom goes into parenting, as the child goes into pre-K. So this piece will just start in pregnancy, but we want to move that through after birth. And this last part, cognitive behavioral responses, can be successful if we have self-awareness as clinicians and medical providers of our own thought process of stigmas that we may carry, that we work through daily, which helps us with language as well as behavior responses that we have toward the patient. And as the patient sees that and they understand that genuineness, it will actually assist your patient to move forward and to be really in tune with themselves and want to make those various changes that we work on. There's some communication skills and harm reduction language that we worked on already on the previous slide, but having open-ended questions, reflective and active listening, and affirming with your patient, affirming that you recognize that there has been a change, even if it's the smallest change. When we value our patient and we're working with our own stigmas, we actually will affirm when your patient may decide that they smoked less cigarettes, or they decided to use the breathing mechanisms that you taught them instead of smoking the marijuana, instead of going to other substances. You opened up one way that this patient is able to handle things in a more productive manner, which helps with pregnancy and after birth. The one piece that I often express is summarizing. Sometimes we wait until the very end of our counseling session to summarize. You actually want to summarize every 12 to 15 minutes. If you are in a 45-minute session, the first few minutes, of course, you talk about the weather, then you move on and you start processing. But take a pause to really see where your patient is. So every 12 to 15 minutes. If you are a provider and you're doing a 15-minute OBGYN, listening to the heartbeat, following through, doing all the procedures that is required from the AMA, within the next 7 minutes, do a summary and see what the patient understands. That creates much better open communication and development of the therapeutic relationship that you're working with, which helps when your patient is in trouble, they will be able to talk. Some harm reduction phrases that I wanted to definitely talk with you about is, how can I help you today? Is a phrase we can use. Also, we can use another phrase, anything that is non-threatening. Always making your patient feel that they are important. When patients feel they are important, your patient will come back and will then tell other friends and other peers that may be going through the exact same situation of how non-threatening and how helpful you were. And the number one piece that I've heard from various different evaluations that we give patients at the end of their pregnancy is they will choose various different OBs in the community and will say, that doctor was not prejudiced against me. They treated me as a person, not as an individual who used drugs or alcohol while I was pregnant. They treated me really well. That means a lot. So just identifying that in that harm reduction phrase can make a difference for your patient. Some body language that I think is important. Remember the second slide I showed you, which was see your patient's heart first. In order to see your patient's heart first, you have to be on the same level as your patient, which means if your patient is sitting and you're standing over the patient, it may be threatening at certain times, especially if you have a patient that has suffered trauma and you may not be aware of that until later on in different conversations. But if you're able to be at eye level, if you're able to, if you have to type on your laptop, make sure that you're not looking down the whole time. Be aware that your eyes should be at least above the screen, and look up every now and then to make sure that the patient knows that you're there, you care, you're with them. I've often told many individuals that I supervise is to learn how to do your keyboard without looking at the keyboard. It may make a big difference because now your patient knows that you're not looking away and you're not interrupting because you are really there with them. You're there emotionally, and they can see that the stigmas have been pushed aside. Be careful of crossing our arms. I know when we're really in deep thought, I do it too. I cross my arms, or I cross one arm and then I have my hand on my chin because I'm really thinking hard about how I can handle this. But as arms are crossed, it gives a thought of, I want to kind of get this through, get this over with. We want to always keep an open communication, open mind for all your patients. Eliciting conversation also helps to make sure that that stigma is not showing. Eye contact, clarify the information, use pamphlets, make sure that pamphlets are written in the language that your patient understands. Seeing if there is an interpreter that might be needed for a patient. Find out when a patient makes an appointment, what extra services does the patient require in order to make sure that this is an effective, most positive experience for this patient. Find out what they need. Make sure that you've trained your front line staff, your receptionists on their own biases, on how they're actually following through with various ways of communication with the patients that are seen by them first, then by you second. So really making sure that that information is given and coming across in most positive experiences from the time your patient comes in the front door and then into the office and then back out the door. Avoid jargon as much as possible and offer time for the patient to reflect. Some patients, it may take them a little while. For some of my patients, when they go to the OBGYN office, I often express to them how important it is to take a pad and a pen in the office with them so that they're able to sit up and write down some questions that might be needed, or they can write down the questions before going to the office and actually handing the questions to the provider or to the medical assistant to say, these are the questions I have. Do you think the doctor will have enough time to go through them with me? That helps actually. Most patients are not used to feeling important and seeing themselves as an important part of their own treatment. You're giving them power to do that, which also actually helps to elicit positive behavior. Be aware of facial expressions. I have them too. There's some stories that may come out that are really interesting, and our facial expressions may show that. So for the most part, as long as we're being supportive and we're seeing the patient from the heart, we're able to actually control those facial expressions. Provide language that increases dialogue. That language will be, how can I help you with this? Is there any parts of our examination today that you are concerned about? Is there anything that I can do to make this seem a little bit easier for you? What services would you like? Those types of questions actually, and that language increases the dialogue between yourself and your patient. Lastly, process and respond to the information provided. Now that can be tricky. So what happens when I have written here to process and respond, your patient will ask you a specific question respond to just that question. After you have processed that and responded to just the question the patient said, now you can add positive language to it. With that said, I have a little bit more information I would like to give. Is that okay with you? Now you can give a longer answer, but what you're doing is you're making your patient aware that you're going to give a little bit more meat to the answer that you've already given because it's important. And that actually helps. The main stigma that majority of our patients have had over the years is not feeling important and not feeling that they matter. So responding and processing and then asking, can I add more? Or may I add more? That actually has your patient thinking in a different way and understanding about collaboration and not authoritative type of relationship. Some other illicit responses that I have for you. How does this apply to you? I wonder what all this means to you. What do you think is the next step for you? This last area here, I have found to be remarkable when I'm working with my patients. If we go through the OB office and they come to me afterwards and the OB says, we're really concerned about your blood work. We're concerned that there may be a possibility of gestational diabetes. We're going to send you for another test. Patient may not ask questions about that in the office, but when they come to positive direction and they tell me, my question is, what do you think our next step is after you've gotten that information? What next steps do you think we should do? First thing the patient will say is, I think I need to eat better. Okay, so let's start looking at how I can help you with that. Maybe we need to look at a dietitian. Maybe we need to follow through with other areas that we could help you with. So really asking your patient to think about what their next steps are is important too. The last area that we want to look at that's related to biases is looking at trauma. Some individuals in the field following through may say trauma happens over there, but what we have found through research is that trauma happens everywhere. There is no blanket statement about trauma. It can be anywhere within an individual's life, in their home, in their environment, in their school. I've had students that I've taught over the years, and a few have said to me, well, trauma is self-induced. And I always say to them, patients do not make a decision to be traumatized. So I have to really always express to my students that it's very important to understand that trauma can happen anywhere at any time. And as clinicians, you want to expect that. You want to listen for it, and you want to be able to give appropriate levels of care to help your patients through the trauma. So I always really express how important it is that we really look at trauma. With complex trauma, we know that there's 3 or 4 types of trauma exposure. And if there's 3 or more types, then we have what's called complex trauma. We all are aware of the complex trauma that may happen, and it happens a lot in addiction. And when you have pregnant patients, please identify if there has been any previous trauma, especially complex trauma, because it will negatively impact the child's development if we're not able to recognize and deal with it. There's also lasting effects that are negative for mom, for baby, and for family members. So identifying what that trauma is first with positive direction. When a patient comes in, there are screening tools that are given, and the number 1 screening tool that's always given is trauma screening tools. Those trauma screening tools really help us to identify how we can actually look at this before mom gives birth. This way, it really is very helpful for the baby's development. understanding that if we find that there's trauma within our patients, that we really take a good look at constant support, and also requiring more mental health counseling and focusing on strong relationships. And majority of the time, our strong relationships that I look at first and refer first are peer support specialists. In summary, through the talk today and how we're able to intervene and to eliminate implicit bias is for us to be aware of our own biases and aware of how our biases, cognitive processes throughout and behaviors turns into various language. We want to have an institutional awareness regarding biases, making sure that there is a welcome, a genuine welcome mat for the patient from the time they walk in the door, sees their medical provider or clinician who's providing support for them through counseling, and making sure that there are ways that our institutions are able to let the patients know that they are valued and important, and we're here to collaborate together. By collaboration, I really wanted during the talk that we were able to understand about open conversations and having those open conversations often. Those conversations mean a lot and can carry on past pregnancy into parenting, that transitions to having open conversations that are substantial in school settings and daycare settings where children are being taken care of. We want to also follow through with the references that I have for you for the talk for today. If you would need a copy of our PowerPoint that was used for today, I have no problem with that. I can forward that over. Once we have completed with everything for this afternoon, I want to make sure that everyone is able to give their information so that we can mail out your certificates for your 1 credit hour of CEUs. On the screen is my contact information, and then also phone number and fax number in the website for positive direction if you need it.
Thank you, Dr. Moss. That was great information.
Thank you. Thank you so much for taking the time. I did try to leave at least 5 to 6 minutes for questions. If you had any questions in the chat, or if there were any questions that came that people just want to ask. I'm not sure if you wanted them to unmute to ask or just in the chat or Q&A section of Zoom.
Yeah, and all work. If you want to use the chat, if you have questions, the Q&A, or you may unmute and ask questions. No questions yet. Oh, here's one. This was great information. And I really enjoyed listening to all this information, and I agree.
Thank you. I'm glad.
Does anyone else have any questions? Okay. Well, I want to thank everyone for joining us today. This was recorded, so if you go to, I'm going to put in the chat our website at Western New York Rural Area Health Education Center. Once we will be posting all of our webinars on that website. We got another thank you for all of our information. And if you have any questions too, you can email me. We will be having, so this is our final webinar. We will be having an in-person event on the 19th. If anyone is interested, you can contact me. If there's no more questions, I'm going to say have a great week. Have a great day. We have another thank you. Yes, thank you, Davina. This was wonderful. And if you're interested in our in-person conference, that's going to be on May 19th. Please get a hold of me, and I hope everyone has a great week. Bye now.
All right, thank you, Erin. And thank you, Jessie.
Thank you, Jessie. Bye.